Good morning, everyone. Good morning. All right, we're excited. How many of us got to hang out with us yesterday for day one? I just have to say, I don't get a chance to brag that much, but I thought day one was pretty good, y'all. Yeah? Day one was pretty doggone good. We were beyond capacity for many of the sessions. And again, I want to take this time to acknowledge the team, my staff members, Tracy Gatis, Mary Carlee, Val Davis, other members of our staff for the programs, and essential staff of the Division of Diversity and Educational Equity Achievement. I want to say thanks for helping make this a momentous event for us and a huge success. So today, I want to begin, as I did yesterday, by honoring the fact that our local First Nation, the Ho-Chunk, we are on their land. The name Ho-Chunk means people of the big voice, and today we are here to honor all voices in many ways. This year's Diversity Forum offers a day two, a special training workshop. Our theme, Together Building Cultural Capacity. There are over 250 of you who were able to join us today, and we had a wait list. Over 100 individuals also wanted to be here. I should note that this day came about as a result of a conversation I had with a good colleague of mine, Ron Luskin. Is Ron in the room today? Where are you, Ron? Ron Luskin. He approached me about 2 years ago, ran a similar conference and had an overflow capacity, I think about 100 folk, and I said, well, hey, why don't we build on that momentum and create an experience here? And by gosh, we still have the same thing. So I think this is an issue of interest and support and topic for individuals to engage. Many of you come from mental health professional backgrounds, student services professionals and advisors, and you're here to find ways to build those bridges and merge new opportunities, new insights on how to be more effective in your role in supporting students. We know there is a pressing need to better serve students, particularly those in need of help, many of whom are coming from diverse ethnic and cultural backgrounds. And we hope that by attending the workshops today, you feel better equipped to meet the mental health and well-being needs of everyone that we come in contact with. Now it's time for me to introduce to you our keynote speaker, Dr. Sarah Van Orman, who we are extremely lucky to have her here, right? Dr. Van Orman was our former director of University Health Services, but she's back. She did us a favor, so we asked her before she left, so, you know, we kind of leaned on a little bit. Come on, girlfriend, come on back, right? But during her time at UW-Madison, she restructured University Health Services to better address mental health issues and provide counseling for incidents of bias reports on our campus. She also worked to combat high-risk alcohol consumption amongst first-year students. Van Orman recently joined the University of Southern California as Associate Vice Provost for Student Health and Chief Health Officer for Student Health. In her new role, she manages all student health services at USC and will develop a comprehensive public health approach to student wellness and care based on student and campus needs. Today, Dr. Van Orman will talk about health disparities within college populations and discuss their impact on educational disparities. She'll talk about measuring and addressing health disparities on campus to provide a sample framework for health equities on campus. Please, a warm welcome for Dr. Sarah Van Orman. Thank you.
Well, good morning, everybody. It is such a pleasure to be here. I want to thank, first of all, Professor Sims for inviting me back today, and thank all of you for being here. It was wonderful to come in this morning and see so many friends. I also was really great to wake up and have, like, I put gloves on and a coat. It was very exciting after being in Los Angeles. So. The trees were turning, so, but no, it really is an honor. And I also want to take a moment to commend all of you for that work that you're doing here at Wisconsin to make sure that this is a place that all students and all members of our community can learn and flourish and grow. And this is hard work and this is interesting work. I actually flew in last night from Atlanta from the American Public Health Association national meeting. And it was a very inspiring meeting, but a lot of the conversation was about how do we achieve health equity for all individuals in our country. Many of the sessions were about really trying to understand how the social determinants of health impact people's health and well-being and their ability to flourish. So I think of what we're going to talk about today as a little bit of a microcosm of that, about how do we think about and do this work here on our campus here at UW-Madison, and how do we think about these issues of health equity among college students, and how they have a really significant impact on educational equity. I have no conflicts of interest. I guess you're paying me to be here, so maybe that's a conflict of interest, but yeah. So I'm going to start with some definitions, and my talk today I think is a little bit at a 30,000-foot level about health equity and educational disparities, and then I think today your workshops are going to talk about how you get down into how those play out on a day-to-day basis with care. But I think it's important, first of all, that we think about and just understand the language of what we're talking about. So in healthcare right now, and we talk a lot about the idea of population health. And this is really kind of a guiding feature of how we start to think about this, particularly when we're designing systems of care and health systems of care. I think of what University Health Services does and what college health centers do as doing a little bit of doing population health, that we're really looking at sort of the health of the students that are on our campus, and more importantly, we're looking at what the outcomes of different students are among that group. And when we see differential health outcomes, how do we address those? We understand deeply in healthcare that the social determinants of health are powerful, and that if we don't consider social determinants of health and how we design systems and we deliver care, we're going to be ineffective in what we do. This is true at college campuses, and this is true nationally. And social determinants of health are really looking at what are the conditions in which people are born, grow up, live, work, age. What are the systems in which we deal with their health, and in many times their educational systems, and how those circumstances interplay with economics, with social policies, with racism, with politics, to determine people's health. And ideally, we want health equity. That means that people have the opportunity to have their full health potential, and I would argue their full educational potential that isn't determined by social determinants of health. Three related concepts are the idea of a health disparity, a health inequity, and a healthcare disparity. We're going to spend some time today talking about the difference between health disparities and healthcare disparities. Both are very important, and the workshops that you attend today talk a lot about addressing healthcare disparities, which have to do with what are the differences in the care that someone gets. And those are an important contributor to health disparities and health inequities, but they're not the only factor. Most of the contributors to health disparities and health inequities, as we're going to talk about, really have little to do with what happens in healthcare. Healthcare can contribute to them. It can be a secondary or tertiary prevention to try to address health disparities and health inequities. But as practitioners, we're charged with not only addressing healthcare disparities, but I would argue that we're also charged with how do we stand up and be a force to address health inequities and health disparities. And I'm not going to read the definitions there, but you can see that really health disparities and health inequities are when we look at differences in health outcomes among people that are systemic, avoidable, and I highlight the word avoidable, and unjust. So what's the frame that we start to think about this in? And I'm going to provide two frames to think about. So when we think about what we're doing in healthcare, I always bring us back to the triple aim, and those people who worked at UHS know I can't give a talk without the triple aim, and they're going to know I'm going to talk about the quadruple aim in a moment. That we, as a healthcare system, and I would argue any of you that work within any healthcare organization are part of a healthcare system, and many of the people that work within student services are actually part of a healthcare system. I'm going to talk about that as well. That we want to make people healthy, we want to enhance their experience of care, and we want to be effective in that. So one of the things that the IHI says when they talk about the triple aim, they talk about healthcare and doing this in the context of other systems that are around that individual. And they provide this model that says that healthcare interacts with public health and interacts with social services. And those are the things that kind of compromise the system that surrounds individuals who have health needs. I would argue that when we think about ourselves on a college campus, that we could change some of those labels in those boxes, but we actually do all of that. Social services really are our resident advisors. There are wonderful officers in our police department. They're the people that are in our student services office. That those are the individuals that kind of create the social fabric, that the net around which our students work. And public health are functions that all of us play in terms of advancing the population health. We do this all on our campuses because our goal here is to create students that are ready to learn, that are able to achieve their full educational potential. So when we're delivering care, and I mean that in the broadest sense on our campuses, we are trying to help our students be happy, to be healthy. We obviously need to consider resources, and we're trying to get them ready to go into the classroom. And it takes all of us, whether we're in the examination room, the consultation room, the offices of the Dean of Students, to make that happen. So how do we think about health? So my favorite model in thinking about health, and it will help us start to think about what drives health, is this model this is actually from the Population Health Institute at the University of Wisconsin. And I will note that at APHA, this was shown in about 3 presentations I went to nationally. So this is a really important model as we think about this. So as we start to think about how systemic forces and these larger issues in our society, that social determinants of health come into play, I think it's important to think about what drives health. And this is a pretty well-researched model that says when we look at how long someone lives and what their health is going to be, that what we actually do in clinical settings is a very small piece of that. So I'm a physician, so I'll own that. You know, what I do isn't that important. We own a little piece of it. It's very important for the individuals who need our care, but it only probably contributes about 20% to how healthy people are. The other things that contribute the most are actually the social and the economic factors. The things that affect people's employment, their education, their income, their family, their social support, their feelings of safety that they have in their community. Those are the things that really drive health and where we need to intervene if we're going to be effective. Similarly, our physical environment, our air quality, our water quality are very important. And then we know that health behaviors are certainly an important contributor, and those are many times intimately interconnected with some social and economic factors. And when we start to understand how social determinants are so powerful in terms of health and how they contribute to health, I think this is a very helpful model to think about that. So then let's transition a bit to understanding what is it that contributes to health inequities. And this is a model from the Bay Area Regional Health Inequities Initiative that I really like in thinking about this. So I want to spend a little bit of time on this. So when we think about it, we talk about there being these upstream factors and there's being these downstream factors. And it's really important to think when we go upstream, we think about the ultimate contributors. We understand that right here, we look at social inequities. These are really, in many ways, the root cause of the disparities that we see in health, and I'm going to argue in education. This is where the impact of racism, of xenophobia, of homophobia, of transphobia, of all the things that we think about as contributing to things we want to change in terms of our climate, these are powerful drivers of health. And ultimately, when we want to look at what the ultimate root cause, the upstream cause is, these are the things that we want to be working on. So the work that we do in terms of diversity and inclusion are the most powerful in many ways upstream force. We know that they contribute to institutional inequities, things such as policies, laws, how the environment is. They contribute to living conditions, they contribute to people's income and education. We understand then that those then can contribute to risk behaviors, to disease and injury, and ultimately to mortality and morbidity. So this is really the model that when we're in, and I think it's tricky for practitioners, but I think it's also important that when you're in that examination or that consultation room, that you understand that the work that you're doing may be right there, but it's existing in this larger context of factors that are influencing people's health and well-being. Now, we have a powerful role to play as practitioners and individuals, both in terms of the care that we deliver. First of all, to make sure the care that we're delivering is not actually through our own lens of our inability or ability to be culturally competent, is not contributing further to health disparities, but also in understanding how the care that we can provide, and I'm glad there's a session on ACEs this afternoon, or adverse childhood experiences, really powerful to understand what we can do and how we can understand that those experiences can contribute to actually improving health and changing the trajectory for our students. But I also think it's important for us, as we understand the experience of students in our campus, that in many cases, and I think our campus climate survey showed that, our students are continuing to experience racism, continuing to experience homophobia, things that actually are continuing to contribute to the environment in which they're living right here on our campus. So this is the model we want to think about, and we want to think about how we can both be good at healthcare, but how can we be advocates for understanding the systemic factors that may be contributing to health outcomes and actually educational outcomes. I was so excited to see a presentation this afternoon on the Adverse Childhood Experiences study. This is powerful work. I encourage you, if you have not, if you do not familiar with this work and this literature, to attend that session this afternoon. I'll just mention it briefly. It was a large study actually out of Kaiser in California, and they really interesting longitudinal study where they looked at these experiences that children had in childhood in terms of what we call traumatic stressors, such as exposure to abuse, neglect, that was both within their families but also within their communities. And what they found is that they're common. A lot of children had one, and it had a very powerful predictor for health outcomes as well as quality of life, things like educational attainment, social problems, for the rest of their life. It's powerful work, and I think what's really interesting as college health or people on college campuses is what is our ability to understand the experience of students who may have had traumatic stressors at a younger age, and potentially address them for them to get through supportive communities, good mental health care, and potentially mitigate and change the trajectory of how these experiences may be affecting students' future health and well-being. So then let's talk a little bit about college students. So one of the things I think that's also very important as we think about the impacts of health inequities and in our students is to understand that college students are changing, and they're changing in a really profound way. This is a great graphic I love from the Bill and Melinda Gates Foundation that looks at America as 100 college students. It's small print, but if you dig down into it, we can see that the students that are coming to our campuses, whether that be at UW-Madison or MATC or UW-Whitewater or UW-Fond du Lac, which I think is going away. I mean, it's all changing. But what's happening throughout our system, they are different than they were 20 years ago. They're more likely to be female, but they're also more likely to be first generation, to be older, to be students of color, to be international students, to students that may be coming to campus with increased financial burden. And you can just see there, and then international, and you can see right there the changing demographics, that college students in the United States have decreased from 84% white 25 years ago to now about 61% white. So our campuses are increasingly diverse, and they may, so when we think about the institutional impacts of these factors that are the social determinants, that's very real for the students that are coming on our campus and are impacting their health. So we are in the business of graduating students from college. And we are in the business of doing it quickly within 4 years, right? That's our goal. Because we think that students who are able to graduate in a timely manner, they achieve less debt. It's good for our system, it's good for our campus, and it's good for our students. We know here at UW-Madison, and I apologize for the language on this slide, this is language from the IPEDS, the institutional database. We know here at UW-Madison that student graduation and retention rate varies profoundly and varies very significantly on the basis of social determinants of health. And the data we have to do with race and ethnicity. We don't have data of this for other factors, but we understand that students have different experiences in terms of their ability to graduate and their ability to graduate on time. Or graduate within that 4 years, which we know is better for students. There's a lot of factors that impact that, but what I argue, or what we did when we were at UHS and we started thinking about this, is trying to understand how the health status of students, and more importantly than health status, how these social determinants in terms of income level, social support, being engaged in the community, feeling part of our community, may be impacting this. And ultimately, when we think about what's the ultimate measure of how successful we're being here, this is maybe one of the ultimate measures. So students being able to flourish and graduate is extremely important. And we can understand, and those of you who had a chance to kind of look at this while I've been talking, to understand that there are real differences for student groups. And if we don't think about and start to peel back and understand what the root cause of those differences are, those are going to persist. And so I think this is the one way to look at it. So what do we know about the presence of health disparities within college students? And what do we know about them, particularly as it relates to what I'm going to call the big four? So we, first of all, college students, most students are in good, by all external appearances, are in good health. Not all students, but most are. We know that the things that students come to UHS for are when they're sick, when they're injured, and for mental health. Those are the three things that bring students to us. Many students are healthy, but what we're really looking at is their long-term health. Some students get sick and we want to get them back to health, and some students have chronic illnesses. And many of those are actually mental health conditions: depression, anxiety, post-traumatic stress disorder. Those are the most common. We look at the complex chronic conditions we serve, that's it. So thinking of a generally then healthy population of students, I think one of the mistakes that's been made when we think about college students, and there isn't much in the literature about health equity in college students, is this idea that they are healthy, right? They are doing just fine. They're privileged, they've made it to campus, there aren't health disparities within that population. But I think there's actually really profound literature and really important literature, both on our campus as well as nationally, that's not the case. So we started at UHS to just figure out, how do we measure this? How do we start to think about health disparities within the student population? And even just as a snapshot, we would follow this every year. And this is from a year ago, because I don't have this fall's data, because I don't work there anymore. Even if we look at who comes into UHS, there's a difference. And whether that means those students don't need care, I don't think that's probably the case. This is the percent of students that would, of the registered student population in any given year, that would have at least one visit to university health services. And this is a number we followed as one of our outcome measures. But you can see that there were differences. And there were students that were probably not getting care. Was that because they didn't know about us? Was that because the care we were providing was not culturally appropriate for them, that they didn't feel included, that they didn't feel welcome, they didn't feel like the care providers were meeting their needs? I don't know, probably all of those. But you can see that this is pretty profound, actually, and 5 percentage points difference in utilization is a real measure. So that's one measure. But then let's look at these. I'm going to move then to transition to talk about what I call the big four. So when I talk about public health, when I talk about health issues in college students, there's really four things. And what I want to argue is that if we view these from a health equity lens, we're going to start to see really powerful intersections between them, and we're going to start to see really powerful places where we need to address these together. So the big four are the things that we know have the greatest impact from a public health standpoint, from a population standpoint, and that are immediate issues that are impacting student well-being: sexual assault, misconduct, high-risk alcohol use, mental health, and diversity inclusion. And we'll come back to diversity and inclusion, which is really the work that we're doing here today. So let's start with sexual assault and misconduct. We at UW-Madison, as well as at University of Southern California, participated in the AAU Sexual Assault and Misconduct Survey. That was in the spring of 2015. It's going to be repeated this spring. It's going to be offered to campuses. Before I talk about Madison's data, I actually have USC's data. I went through and looked at it, and it looks very similar, so we shouldn't, I think it's very similar in most campuses. We can see really significant health disparities, and I would argue health inequities, when we look at the students that may be experiencing sexual violence on our campus. This looks at the percentage of students who reported either experiencing sexual assault or misconduct, and we look at it by gender and by disability status. You can see that while only 5.4% of undergraduate males did, 27.6% of undergraduate females. When we look at students with a disability, however, 28% of students with a disability, that's graduate and professional, and 45% of female undergraduates with a disability had experienced a sexual assault or misconduct on this survey. That's a health disparity, and I would argue that's a health inequity. Other groups that were disproportionately impacted included students who identified as LGBTQ, where we have 43.2% of undergraduate females who identified as LGBTQ reported experiencing either sexual assault or other forms of sexual misconduct while they were a student here. And then similarly, when we look at American Indian, Alaska Native students, 40.1% of those students did. So this public health problem, sexual violence, is disproportionately impacting students on the basis of social determinants. The second, number two of the big four, is alcohol consumption. Now, alcohol is really interesting. Alcohol is interesting because we actually see differences in the rate of high-risk alcohol consumption, and we see differences in what I consider what I'm going to call secondhand effects of alcohol use. And I'm borrowing a little bit from Rhonda Washington, who's sitting right there in the audience, who's done profound, really national work on this issue. So we know that high-risk alcohol consumption also differs really significantly on the basis of certain factors, including some of the social determinants. Students of color drink a lot less, and as do international students. So you can see here, this is going across the bottom are people who don't drink, people who don't drink very often or didn't drink in the couple weeks before the survey, people who drink moderately, heavy episodic, that's drinking for more than 4 drinks for women, 5 drinks for men in the past 2 weeks. And then problematic drinkers, those are the people who drink more than 8 drinks in a setting for men, and 8 drinks in a setting for women and 11 for men in the past, last time they drank. And you can see there's really significant differences. Well, over 10% of all students are problematic drinkers and 25% are heavy episodic. People who know me know I could talk a lot more about that. But you can see that for students of color, it's actually half that. For problematic drinkers, it's a third that. And for international students, it's even less in terms of healthy episodic. So these students are engaging in high-risk alcohol use a lot less, and yet they're being disproportionately impacted by the effects of that. And I'll add just a couple of slides on this. When we looked at that AU data, we knew that students that experienced sexual violence, alcohol was an extremely common proximate factor. And then the other set of data, and this is Rionda's data, was from a study she did from the color of drinking. When we asked students about if they had experienced microaggressions from other students on campus, we found this was a survey of students of color done about 4 years ago. I know Rionda's working to update this with a little bit more quantitative data. We knew that 30% of students had experienced those on our campus, and we knew a significant number of those happened when students were intoxicated or consuming heavily. So we have this other public health problem of alcohol that is a behavior that's being engaged in disproportionately by our majority students. And it is a proximate environmental factor in many of the experiences of students who are experiencing overt racism, acts of discrimination, and harassment on our campus. And this figure is really important because it fits with what we hear from students, that those high-risk alcohol consumption environments are many times many of the places in which we see this. So then the third item we want to talk about on the list is mental health. So mental health is, again, very common that college students, we see challenges with mental health. We know that nationally, we're seeing students' mental health on surveys of incoming students is declining. For example, we saw between 2009 and 2014, the percentage of students that felt frequently depressed rose over 10 percentage points. We also know that on our campus, along with many campuses nationally, less than a quarter of students with mental health symptoms are getting treatment. Only a third of students with depression report being in treatment, and this is national data from the Healthy Mind Study. Only half the students who are suicidal reported being in treatment. And even for students in treatment, less than 25% of those students were adequately treated. But what we also know about mental health data on college campuses is that male students, students of color, international students on all surveys, nationally, all campuses are much less likely to be in treatment. So for mental health, we have both, and we'll talk about how systemic issues of racism and classism and homophobia contribute to poor mental health. So we have students on our campuses who are having experiences that are impacting mental health, and they're much less likely to actually get treatment when they experience those issues. So what did we find at UW-Madison? So in 2016, we did what's called the Healthy Mind Study, which is where that national data just came from. It was a survey of students. It's a very nice instrument that looks at all kinds of measures of mental health and well-being. And at UW-Madison, we found what a lot of people did, that about a quarter of our students screened positive for depression, 16% for anxiety, 9% for suicidal ideation in the past year, about a quarter were in treatment, and only about a half of students with a positive screen had gotten treatment in the past years. We also found that depression was strongly correlated with students' reported GPA. So our numbers here were very similar to what students were seeing nationally. Mental health concerns were very common, and a lot of students with them were not getting treatment. And when we think about why should we as an institution, we're in the business of delivering education, not healthcare. We think about why we as an institution need to be concerned about this. I would point us to this, and that we also found that depression is strongly correlated with GPA. And that's why we should care about that. That's why mental health concerns we know that they impact students' ability to do what their job is, and that's to learn and to flourish. But what we also found from that Healthy Mind study is that those rates of depression varied significantly on the basis of many factors. So this has to do with the students that participated, again, the 2016 Healthy Mind study, that we can see that this was not evenly distributed across, the prevalence of depression was not evenly distributed across our student population. We can see that African American students, over 20% reported depression, compared with about 14% of white students. Similarly, we can see that Native American students, Arab American students, and Hispanic students were disproportionately impacted by depression. So we understand that students who come from various backgrounds are experiencing depression on our campus at a higher rate. And when they experience it, and I'll share this slide with you, various factors may contribute to their inability or their unwillingness or their barriers to getting help. So this slide looks at among US students, both the level of students who reported that there was stigma about getting help for mental health, and this is the percentage of students who had symptoms that were in treatment. So for US-born students, only about a quarter of them, 40% reported a high level of stigma with getting mental health treatment. And about a third of students who had symptoms reported being in treatment. Now we could argue that that's not great either, that only a third of US-born students who had mental health symptoms were in treatment. But when we compare that to our international students, over half of them reported stigma, and only 13% of international students who had depression in the survey reported being in any kind of treatment. So we can see that there are profound disparities within our student population about both the presence of mental health care treatment, the level of stigma they have associated with it, and their access to treatment. So made the case, right, that there's some intersections here, that there's some differential distribution of these conditions across different student groups, and that there are some differences in treatment. But I think the most profound intersection has to do with how the lived experience of many students is actually continuing to impact their health and well-being. So this was another custom question that was on this Healthy Minds survey. Oh, I'm sorry, this didn't turn out. Ooh, gosh, that's bad. All right, we'll talk you through it. It's a great slide. Oh my gosh, it's so good. So the question here, I'll read it, says, bias and discrimination affects my well-being. And one is strongly agree, strongly disagree, strongly agree, strongly disagree. And the differences have to do with this slide on the right here are non-African American students, Black or African American students. This slide right here are African American students. So we see this profoundly different experience where our African American and Black students are strongly agreeing, overwhelming, that bias and discrimination is impacting their well-being, compared with the experience of white or non-Black students on our campus. So we think of these as larger societal factors. They certainly are, all these institutional factors, but they're continuing to interact and impact our students every day when they're here on our campus. So I will fix this slide. I'm sorry that it doesn't work. But I think this is probably one of the most interesting points about the mental health data from the Healthy Minds survey. So we found that historically underrepresented marginalized students were more likely to have mental health students. They were more likely to have experience where they didn't feel connected to UW-Madison, and that bias and discrimination affected their health and well-being. We also found the same thing among students who reported they were financially struggling. And international students were interesting. They actually thought the university cared more about their well-being, but they were less likely to come in. We found that stigma was really common, and students with stigma were very unlikely to get treatment. But we also knew that some of our marginalized and historically underrepresented students had much higher levels of stigma than other students. And we also knew that informal help seeking was common. I think what's interesting, I was talking to Patrick this morning about this, is that we look at this data and we compare it to what we found on our campus climate survey, which I know was discussed in detail yesterday. In my mind, much of it, we sort of saw the same thing. We were in the Healthy Minds study, we were looking at this much more from a mental health lens. The students were not feeling like they were connected. They felt like they were having experiences of bias and discrimination. and that those experiences were unequally distributed across the populations, with majority students feeling connected, feeling like they belonged more than students of color or students, LGBTQ students or students with disabilities. It's exactly what the Healthy Mind study, and I pulled this from the handout that came with the release of the climate survey yesterday. And really we're seeing the same thing, that students who feel safe, welcome, included in our community, that experience really differs for students, and students on the flip side who experience bias, discrimination, harassment, that also differs for students. And we can see from the Healthy Minds that this thing on the campus climate survey is probably having a direct effect on students' well-being. So when I come back to the big four, I think it's sort of interesting because we think about these as being separate issues, and yet we see they're very connected. And we see that these issues of diversity and inclusion on our campus are probably less than a separate issue, but actually more of a driver, or one of the drivers that's impacting these other three public health concerns that are present on our campus. And that's really our imperative for continuing to address this. So looking back at our model, we understand that there are these larger forces that were in play in students' lives before they ever came to our campus, and are continuing to play out in terms of kind of their experience in high school, their experience in their home communities, that are contributing to institutional inequities and living conditions, maybe contributing to risk behaviors. But we also see that these things are continuing to play out on our campus, and that if we don't continue to address these sort of upstream factors on our campus, as well as deliver culturally appropriate health care, which I think is very important, we're going to continue to see differences in the health outcomes of individuals and their educational outcomes. So one of the frameworks I think is really helpful is the Institute for Healthcare Improvement put out a framework about how healthcare organizations can achieve health equity. And I would argue we're a healthcare organization. I know not everyone would, but we really are providing clinical care. We're providing a social net around our students. And this talks about the things that an organization can do. So today, you're really going to have a chance to focus on these two. So we're going to talk about healthcare services. So we've got practitioners. So we're looking at how we deploy specific strategies. So we're really going to talk about, are we providing the right kinds of care? Are we making sure all students have access to mental health care, to the services they need? And we're also, I know a lot of the work that we're going to do is looking at implicit bias this afternoon. We're going to talk about how do we, when we're in that room, really work to address the care that we're providing and making sure it's culturally appropriate. And is free of bias, and it helps to address the experiences that students are having on our campus. But I would argue that as a campus, and as you move forward with your our campus work, that we need to do more than that. I think it's also very important as an institution, and that's why it's great to see so many campus leaders here today, that we look at how we have a leadership commitment to improving equity at all levels of the organization, that we figure out how to pay for this. And as the former director of UHS, when we talk about the budget, this is a big deal, but it's an investment that we have to make in order to achieve what we want to as an institution. That we look at our physical environment and we make sure we have healthy behaviors. Those are very important. But I think the most important thing is this little box at the bottom, right? And that is to say that all of us practitioners have this need to think about how do we become active in the community? How do we work to address the upstream factors? And as individuals who are on the front lines, who see the impact that this is having on our patients and our clients and our students that we're caring for, this is sort of where the money is, as they say. And it's at the bottom of the slide, but I think it's the most important thing. So just to wrap up, I would say that, I think that hopefully I've made the case that there are significant disparities and inequities in health outcomes and in the delivery of health care for student populations, and those are a profound driver of educational outcomes. We really have to look at them at both the upstream and the downstream. We need to understand that there are forces and factors that are present both in our larger community and in our students' home communities, but also right here on our campus. And if we want to prove population health as providers, we have to look at the presence of disparities not only in the care that we give and the delivery of health care, but how we look at it in our larger context. So I'll leave you from this wonderful quote from the American Public Health Association that says, "We value all people equally. We optimize the conditions in which people are born, grow, live, work, learn, and age. We work with other sectors to address the factors that influence health, including employment, housing, education, healthcare, public safety, and food. And we name racism as a force in determining how these social determinants are distributed." So that's sort of our call to action as we think about the work that we do here on our campus. So thank you very much.